As we all heard, and over the past couple years, actually, I've been able to come and enjoy this meeting at Rice as it continues to grow, draw more attention, industry partners, young academics, excited minds, trying to understand how data science and AI can impact something that's very important to all of us, the health of ourselves and those around us. So just a great presentations today, and I really enjoyed hearing the talks. We have Jeff from Trinetics. You heard about their approach on how data flows in organization, how important data is. Stephen talking about that connectivity of cognition, humans interacting with machines. You know, there's three possible futures. There's a human-only future, there's a machine-only future. That's not a good one. And then there's this human-machine hybrid future, which is definitely going to be the future that we're going to be living in. So understanding how we interact with those machines is going to be important, as Stephen highlighted. And then Vova, right? We can call you Vova, that's your name? Perfect. Okay, Vova also talked about the importance of making sure we know what we're doing with this stuff because lives are on the line. So they're going to join us here in the panel. They're going to come sit in the seats in the front. And I'm going to ask them to give their thoughts on prediction. Prediction is like a really incredible capability. If you're really, really good at prediction, you should work in the stock market. And you wouldn't even be here. You're probably retired, a very nice place somewhere. But we know prediction is also important for like climate change. We know that the ability to somehow tell the future based on some evidence, some information is incredibly powerful. And we saw just in the past 2 years how the simple thing of predictive text transformed through large language models has just an incredible impact on us. So if we have that kind of prediction capacity, what word fits between these two words? What pixel fits between these two pixels in Midjourney? If we have that kind of predictive capacity, what does it mean for healthcare? And I'm not going to suggest we're going to take little steps. I want to encourage the panel to talk about what does that predictive future look like in healthcare? And then we're going to talk about some barriers and challenges. Maybe, who wants to go first? Any takers? Jeff, you spoke first.
I'm holding the mic.
There you go.
This is for full efficiency. Boy, it's incredibly exciting to think of what could be. And I'll probably keep coming back, right? I'm not the person who's thinking about how to develop the models. I'm trying to make it easier for you guys to do research is kind of how I think of my world and actually Trinetics world. It's like, we can help you do it. So there's great examples, and I hate that I always feel like, but be really careful. But I have to keep saying, but be really careful. But I think the be really careful is about intended uses. So are we telling a clinician, you don't really tell, you guide or guidance, this drug's better than that for this patient. Like you kind of want to be right for that. And docs have feelings like they're seeing the patient, they're touching the patient. You know, in my world, when a clinician chooses A or B, I likely can't figure out why based on the data. There's something, the clinician's talking to them. There's something else, and that's actually called channeling bias. And that's all we see in the data is things like channeling bias. So if we're not thinking about that, then we can, I don't mean get it wrong, but we just have to be thoughtful. I think the last thing I want to say, because it was Volva's comment on teaching and education is actually probably most important. I've been complaining for years that the informaticists aren't taught methods, and the methodologists aren't taught informatics, and I'm in the same place, right? I agree. We've got to figure out a way to do that. When I go to the AMIA conferences, I'm almost always the only epidemiologist. And when I go to the EPI conferences, there's no informaticists there.
Yep.
And it's a huge problem. But I can pass the mic. So that
Oh, I should go.
We'll keep going.
I actually have 2 mics. I'm not sure. Yeah, I agree. We live in very exciting time. I don't think, maybe my talk was a little bit gloomy, but I actually don't.
No, not gloomy at all.
Right. I actually don't feel that way. I think what will happen, it's actually nothing new in a sense, right? So we've already seen the last 50 years that the new technology comes and transforms our lives, right? I went to UCLA when I saw an office from which they sent the first TCP packet, like essentially where the internet as we know today started, right? And it requires a lot of control, a lot of work, a lot of collaboration, but it will happen. I don't believe that we will see one model solve all, right? I don't believe that ChatGPT tomorrow, the 10th version of ChatGPT will answer every question, right, and solve every problem. What I do believe is that ML will repeat successes that are already here. For example, AlphaGo, right? It's fantastic. We see examples where machine learning really fantastic in doing well-defined tasks with clear rewards, right? Chess, Go, right? I mean, something, and see what happens. And I hope this was my point, right? If we live in an environment that is very well defined, controlled, right? And maybe the number of states in action is not so large, I truly believe that ML will achieve fantastic results. And this is what will happen. So to answer, to start this, what I think what will happen is that ML will definitely be widely used in healthcare, but it will not, we will not see one or two models that will solve everything. We will see a sequence of very well fine-tuned models that each one of them will solve very specific task. For example, in radiology, something that will look at fairly fixed types of images and will be able to very well identify if there is a tumor or something else. So this I truly believe. And to follow up on education, I think it's absolutely necessary. It's actually, it has to start already, right? Because what is going on in reality, right? FDA already approved this, I don't know how many, 500 or 200 ML-based devices. They will be deployed, whether or not, I mean, it's just a reality. They're going to be deployed at some point, maybe in next 2 years, 3 years, I don't know when. And then what will happen, people, exactly to follow up on your point, people who are using this, they have no idea how the thing works. It's actually a black box, right? And once, and as we all know, technology never works properly, especially when it's deployed for the first time, right? Once we'll see a problem, we have to have people who at least know how to tune it, who at least know how to kind of play with it, right? So that's, I think, maybe I agree with, maybe the most important point, right? To make a predictive AI a reality in healthcare, we need to start training people who will be able to do both, right? To have these two legs. We'll be able to understand what ML does, and also we'll be able to understand the actual clinical setting. Yeah.
Stephen, what are your thoughts on the future of prediction in health?
I have bad luck to predict my stock market, so very hard to predict futures. But I can see immediately, I good or bad, I look at it this angle. I think first of all is we definitely will see a more efficient hospital process production. I mean, automation, as I mentioned, we have a lot of waste in healthcare today, 30%. And AI, first thing is, will save costs, reduce unnecessary procedure, more precise. This is very positive. You will see more gadget coming in. All these things were going on. Back office, front end, all these things. Radiology, cardiology doing a wonderful thing. There are a lot of interesting product coming out. And this is definitely one area, definitely will be better. Second thing I would think about is also dangerous. It's a post-con. We have a lot of piecemeal automation. That means that every time you introduce a new technology into an organization, just like you introduce Epic into a hospital system, you see so many years preparation, so many against all these things. So likewise, AI now piecemeally we import in different ports. Hospital not even look at it at an enterprise-wide, how to optimize the whole workflow. Basically, I predict hospital need to reorganize their clinical workflow. They'll be coming very soon because end of day return investment, this is how I measure against. I mean, no, healthcare is, even most hospitals are non-profit. End of the day, you still need to run the business. So supposed to put it in, but if no one look at the total workflow, optimizing workflow, I think it will become a disaster. I think eventually people will look at it. The second thing I think about is the technology at a higher level organization actually will changing how we think a hospital should be. The way it's going, likewise, you cannot tell different what's called insurance company, what's called in hospitals anymore. If you look at Kaiser, tell me, Kaiser is an insurance company or hospitals? Right? I would say Kaiser is an insurance company. But everything about Kaiser is a hospital, right? They make their bulk of money, they get all the data, the motivation, all the things. My point, the AI technology will change how we perceive the hospital should be. Another thing is also to physically will change how we think the hospital should be. Think about hospital, you think about Houston Methodist. Nice building, glass, okay, and Wilson, very nice. Brick and mortar, that's over. It's a hospital without wall. We care about the patients is for the lifelong. It's not just episode, you come to hospital, I take care of our hospital, good luck. This is not the way to do it anymore. The technology allows us to continuous care. And that is the overlapping. You get into the insurance territory, right? This is the issue. So I was saying there's two areas. The mention is the technology will change. Right now it's very good in terms of piecemeal automation, but it will change how we define healthcare will be over time.
Okay, if you have questions in the audience, please put up your hands. We're happy to go to you. I mean, I think this is very interesting. There's a pair of books. I don't know if you've had a chance to read them. They're from the Rotman School of Business in Toronto by A.J. Agarwal and other authors. The first one came out about 6 years ago. It's called Prediction Machines. They cast the entire framework of AI and ML as a capacity to have a prediction machine, the power of prediction. They did this great overview of how they see prediction machines coming from AI, the capacity to predict, just like guessing that text between those two words or guessing that pixel in Midjourney. They just came up with recently another book. It's called Power and Prediction, which talks about how prediction changes power structure in society. And the shift to technologies like AI will change the power structure. So each of you have talked about this, actually. How do we respond to how predictive capacity changes the way we work? Jeff Hinton said, we're not going to need radiologists. So somebody responded and said, I need to find another career, for example. He was wrong. He's a very nice guy, by the way. He actually regrets that comment. They actually analyze that comment, and they break down the role of what a radiologist really does. So they prescribe 3 elements of AI. One is this spot welding, a place where you can take an algorithm and solve a little problem today. We see that all over the place, and that's what Stephen was talking about. They also talk about these completely embodied systems, like self-driving car, where all the inputs and all the outputs are fully controlled. Volva's provable paradigm. But then they talk about this next phase, which is exactly what Stephen was talking about. I'm going to ask Jeff a question. The hospitals and the structure side is going to restructure as all this power shifts because of these predictive capacities. So how's our health system, how are our hospitals going to be redesigned? How are we going to educate people? How are we going to flow the data? And I'm curious, Jeff, when you're talking to hospitals and you're talking about your data flow, do they start to ask you, why would we do this for just outside? Why aren't we doing this for inside? Could you comment around the rewiring of hospital data flows? And what are you hearing to respond to this opportunity?
Yeah, boy, it would be great if the hospitals did get kind of redesigned. And I don't know what I should say in this room.
This is all just friends here. They're friends. Yeah, no problem.
Right. So it looks to us, so a lot of what we do is we go into hospital systems, right? We sign them up. We're now partnered. And we say, where's the data? And they're like, whoa, boy, how long do you have? Because there's some here and some there, and the surgical suite data is over there. You're not allowed to touch that. But you have to go over here to get, it is everywhere, which means it's nowhere, right? So, and what that does actually is limit our ability, that's our as a company and ours as a community, to actually use the depth of the data that's actually in the hospital. Because, you know, the radiology reports I might get, maybe, but we're certainly not getting the images, well, there's a whole problem with getting the images and all that stuff, right? And the genomics data, well, that's in the basement. And we don't even have microbiology data that's easy to get at to be able to do AMR resistance kinds of things. It's in a PDF, so it doesn't harm care. The docs know, but I can tell you the rest of the world would benefit if we had that information pulled out. So that's boy, I don't know where I wanted to go with that. The hospital data systems are, I'll just call them siloed, right? The data in the country is siloed, and then the data inside the hospital siloed. I guess when you guys were talking, one of the things that just leapt to mind is change management. It is really hard for any big organization to change. There's nothing more complicated than a hospital, right? And trying to get a hospital to rethink what it does sounds like a really big problem. And I'll have to say, sometimes what you really need, there has to be a financial incentive. So maybe it's saving money. You would hope it would be saving lives if you can prove it, but it might be, EHRs are really good billing machines. But saving money might be the motivator that drives some of that change. It probably has to be.
Yeah, I think
Stephen.
I think the return investment, as I mentioned about, is end of the day, non-profit business is still a business. So it is justified that why should I invest on this? By the way, hospital, we are in hospital because we care about people. So this is a different business for other people. So we do have passion for patient life, even at the cost of losing money. But it cannot last for forever. Sooner or later, the hospital bankrupt, although you were best intention. This is the countries. But it's hard to say, but my point is there are two things. I've been in and out industry and academic for the last 35 years. I see both sides. I hate to say, offend a lot of people, very good IT people don't come to hospitals. Unless it's a very academic-oriented hospital. Then you do research, it's like me, have fun, enjoy it. But most, you go to Google, all my students graduate, go to Google, Amazon. Why are they sticking to IT? It's no fun. It's very hard to attract good people, first of all. Secondly is, you talk about radiology. I've been in radiology 30 years. In fact, our group developed PACS, Picture Archive Communication System. Today, the radiology, we did the first one in UCSF. We created a whole industry. AI at the moment, unfortunately, I don't think it will replace radiologists because AI is still a narrow AI. Radiology, when you come see the image, they put all the heuristic in their brain learning. They are really generic. So no way you can predict, look at image using current AI algorithm to identify what disease it is. The success story you are hearing in radiology is when you look at specific endpoint, lesions, risk of the breast cancer. Those are very good, I mentioned. When you narrow down one thing, AI just like stroke, very good. You have a clear endpoint, you look at it very carefully. But human radiology, their training is generic. So far, we don't have general AI to replace it. So I don't worry about radiologists too much losing their job. But then again, if you look at the history of medicine, every time a worthwhile technology comes in, it does change the organization of medicine. X-ray, radiology starts with X-ray Röntgen, a physicist. There's no radiology, create the whole field. Microscope start, microbiology, create the whole thing like bacteria, the microbiologist. And microscope, you start in creating the pathology. Every time radiology, a lot of discipline, we take it for granted today. They are new. If you go back about 150, 100 years ago, a lot of them just they come up because the technology come up. I predict that AI is one of these groundbreaking technology. Now, I'm not smart enough to tell, but someone very entrepreneurial will figure out and how this new discipline of medicine, physician will come out. I think it will. It's not a traditional guideline. Medicine is very dynamic, and profession is already dynamic. Although we are over specialization, maybe AI become integrate together. But anyway, there will be a very exciting time. That's all it is, I can say.
Okay, thanks, Stephen. We're going to try to keep our responses short because I think we have a couple questions. So one in the back.
Yeah, hi. Thanks for the interesting discussion. I'm Ferris, a research scientist at Houston Methodist in cardiology, which predictive health is really big in cardiology, as it is in many other really important specialties as well. What comes to mind is, and I'd love to hear your take on, is predictive for it to become helpful in the real world. The predictions will have to be actionable, so that predictive will actually become preventive. Hopefully, in many of the ways. But and this is the issue that I think is sometimes overlooked in many areas. What I'd love to hear your take on is, a lot of uptake has to do not just with the algorithm itself, not just with the AI itself, but actually with the people that are supposed to take it up. So for example, there's research about cultural issues where a study that was actually repeated later that people in China are are more likely and more willing to take up and trust AI as compared to people in Germany and the UK specifically. And that so first came on from China and then later replicated in Germany. And so cultural issues, psychological issues, people that are more on the neurotic side are less trustworthy of AI as compared to people that are more extroverted as well. That's also another
Let's
paper
get
that
some
came out.
feedback from the panel.
Yeah.
Once again, let's keep the questions short so we have
Yeah,
lots
sorry
of
about that.
opportunities. Thanks. So panel, what do you think about how prediction can be acted upon? What are your thoughts on how do we facilitate that? If we have prediction, so what? Is it going to be able to be delivered on, actioned on? What are your thoughts?
It's a very hard question. I think it really depends on what. I think maybe it's too general, right? So if we go into something specific, so one of my collaborations, for example, is with Baylor on trying to predict the probability of a stroke in a patient with artificial heart, right? If, and I'm very hopeful that we will improve this, if let's say the prediction rate would be, let's say 95%, right? I think something like that could just transform lives of those patients, right? So this is absolutely fantastic, and we absolutely should work on something like that. But more broadly, I think it's really not clear, right? I mean, in some types of problems, it's very well defined, right? The outcome of this very well defined. The impact is also very well defined. In other type of problems, I think it's much less measurable, right? Maybe we still need to work on this, but it's not clear, and as many people said, how we can measure the impact of the predictive power. And to follow up on your comment about the predictive power of LLMs, for example, right? This is where I see a lot of hope, right? Let's say specifically for mental health, right? So many cases, for example, in many, I'm quite passionate about this. Let's say in many areas where mental health specialists are not available, right? In Ukraine, for example, right? And kids or some other vulnerable populations really need urgent mental health. Something like LLM can be of tremendous help, right? It's very hard to measure this, right? How they will help. And it also needs to be controlled. But I do see a lot of hope here, and the reason why, right? Because in those scenarios, the space of acceptable answers is very large, right? It's not like predicting a function or predicting a stroke, right? It's 0 or 1, right? As you said, the output of LLM in this case, it's any sentence that could be acceptable to the child and comfort, I think, overweights any potential risks or something. Hope that's a reasonable answer.
No, I think it's a really interesting response, I think. So, I mean, to realize the power of prediction, we need to make sure that those who need to make the action have a confidence in it. That's why I was, going to get your response, because to me, there is a trust paradigm that needs to be active if we're going to act on prediction. So how do you get people to understand what probabilities are, what likelihoods are in decision making? So you have to link, I think this was the point, the prediction to the decision maker, but that's something that's not so clear in medicine. That's a skill, that human-machine interface capability.
I see. Yeah, I mean, that's kind of was the point of my talk.
I think if you showed your equations to the patient, I
Right.
think they would be convinced.
Right.
In the spirit of brevity, I'm going to go with AI as a nudge. Right, it's an elbow to the side of the doc. Hey, did you look at this or double check that? As versus a tell versus a. So that's how. If we're thinking about how AI can interface with that clinician, it's a. That kind of really does look like breast cancer. Are you sure? And then leave it at that, or that really, I'll go with AI as a nudge.
I mean, the technology and human interaction is still driving in this direction, and yet most, patients interact with the healthcare system through somebody else.
So actually, I think about, it all depends how you measure it. In this case, if your predictive model is so good, and it's passed by CMS, I'm sure everybody will use it. The problem is everybody say I have this good predictive score, and that is wonderful, can cure everything, but CMS look at it, say not worth the money, I don't approve it. So you go back to look at how repeatable is your score is. That's one of the issue here. Easier to get a whole bunch of number and get result in the one or two side. In terms of AI, frankly, I keep on saying that. We are using MRI CT every day. Have you questioned how the algorithm works? Today's MRI CT embedded all the AI algorithm using that every day we are using it. We trust the system. We look at it, right? So I think the issue, to answer your issue, is the predictive model, whatever you have, you need to prove the value to CMS. You want the people to use it.
Okay, Stephen, we're going to go to the question here. Another Stephen, I think, had a question.
Hello, I work in the EHR industry, most specifically for insurance compliance. But the problem I see in my company is that there's no trust between the company and the doctors who are to use it. So how can we foster that trust or collaboration?
Quick response from the panel.
What's the question?
What was the question?
How do we foster trust between insurance and providers?
Oh, sure.
No takers on that one?
Look, I was say, insurance data is actually the only really, really reliable standardized data in the country. And it's because we won't pay you, we insurance company, I used to work at an insurance company.
Confessions here on the panel.
It was also at Harvard, it was a whole complicated thing, but insurance companies pay for standardized data delivered the right way. The most beautiful data in the country is pharmacy data, not the prescription data in the hospitals, that's a mess. Pharmacy data is incredibly reliable. Hospital data that is submitted to an insurance company is very reliable. Why? Because if you, the hospital, put the wrong information in there, you're stealing. Full stop. You're stealing. And it used to be, we used to just say, I don't look good in orange. Like, I don't want to go to jail. So if you
I agree, Jeff, you wouldn't look good in orange.
Right? So insurance actually brings some level of standardization that's really pretty interesting. I don't know
we're
about
going to
the
go to the
trust.
next question in the back.
Hi,
Where are
I'm
you
from the
Did
School
you
of
say who you are? What's your background?
Yeah.
Real quick.
So my name is Kamlesh Yadav. I'm from the School of Engineering Medicine, Texas A&M. So with the advancement of predictive health in medical diagnosis, and now we have, say, for example, diabetic retinopathy now doesn't need a pathologist to sign off. What do you think, and I'd like to get your input for the three people involved in medical education, the medical students around here, and the actual clinicians, how do you think their role is going to change in this particular scenario?
So role change and the impact of AI direct for diagnosis.
Maybe you guys can go first.
Who wants to take that?
What's the question?
Role change, how it will change the roles in healthcare.
I still don't quite understand.
How does the use of predictive capacity, in particular in diabetic retinopathy, likely to change the roles in healthcare?
Well, I'll just say, because I'm going back to the beginning, I think it's going to change the role of education in healthcare incredibly, because you're going to have classes you didn't have before, right? Because you're going to be the users of this technology, and you probably need to understand it.
I think, so I'm not sure about roles, but this is another topic that I think maybe has not been discussed much, which is very important and related to this. I think it's a topic of liability. Right? So in those roles, let's say if the particular AI algorithm fails, who is liable? And that's maybe would redefine those roles, right? Is it the liability of a particular AI algorithm, and then the software company that developed it has more important role, or is it still a liability of the same clinician who used it?
Oh, that's very clear, actually. This is a very common law. So basically, the one who build the product are liable.
Really?
Yeah.
Well, that's very interesting.
Stephen, could you speak up again? I didn't quite hear the answer. What did you say?
There's a very general law, basically. It's just if whoever build the product and fail the product, is reliable. Now, if the hospital clinicians misuse the product, it's a different story. You have to prove it. Otherwise, whoever sell the product, for GE create MRI, reconstruct the image wrongly, and lead to the wrong conclusion, GE reliable. That's very clear. This is.
Well, I think there's a question there. I'll just add one little bit. We had Mark Abramoff, who led a lot of these development of these technologies for fully autonomous, retinopathy analysis.
Yeah.
And fully autonomous, which gives you an answer with a machine that captures the data, that encapsulated self-driving car kind of paradigm, that I think is really clear. The question I asked him when he presented recently was, in this tool that's been approved by FDA, if the clinician misapplies it in the wrong population, who is responsible then? And I think it's quite unclear. And that's where the data that makes sure we know whether this is the appropriate use will still be held by the health systems. Okay, good question.
George Golovko, UTMB. I would like to hear your opinion about the education. So do you think we need to train data scientists to understand the medicine, and they will be the future who would help with AI and treatment? Or do we need to train doctors data science? And in your response, I would like to hear which one would you use to raise the capital or approach an age grant, and which one you would trust to treat you using AI?
So which one is it? Is it data scientists treating patients or physicians learning data science?
Actually, when I think a lot of people work on medical informatics before. Many years ago, when medical informatics started, there's a lot of PhD there. Nowadays, all the doctors think they know medical informatics. They go to AMF meeting, all the people say they are great. And I see the trend happening in bioinformatics. Biologists start thinking about they know all the biologists. The reason I start observe it become like that because the tools become available and become stabilized. And not many new tools coming out. People know how to use the tools already, just like radiologists know how to use the MRI scanning without understanding the reconstruction case-based algorithm. I think that, to answer your questions, is that if a tool becomes mature, the user will use it. When you read a lot of data scientists, because it's still a black magic. So right now we are in the fuzzy stage. I think, but in a couple more years, hopefully stabilized, I think you will be becoming a user, hopefully, knowledgeable using this tool. End of the day, they have the domain knowledge. They're certified to care for the patients. That's my opinion.
Okay, got a question in the back.
Hi, my name is Mohammed. I'm from Rice University Computer Science Department. So my question would be more computational. So I was thinking about the bottleneck in trusting the machines in decision makings, and I think that the bottleneck, or part of the bottleneck, would be the reasoning. So, for example, you have one large language model, and you want to see what's the reason that it says the outcome. The best strategy would be like taking action A. So you can do some kind of interrogation, asking, why did you decide A? And then it goes back to B, and B, why did you say about B? And we go back to the root cause of that. So that could be imitation, but not reasoning. So my question is that how do you teach a machine reasoning? How do you feed them with the axioms? Like the axioms that people, the logical axioms that human beings use. So I think that would be a bottleneck.
Who wants to tackle the reasoning problem?
I should try, yeah. So first of all, it's a fantastic question, right? And I think many people, as I said, right, there is a huge effort now on the theoretical machine learning community who try to answer this question. The first paper that I've seen that comes out that try to understand generalization of transformers and of LLMs. The current trend that I've seen is that those models actually don't try to estimate the function that you want to optimize, but they try to estimate a set of algorithms that can compute this function. And so inside this set of and this also explains, kind of why when you try to engage in a dialogue with LLMs, they will navigate in different directions, right, and give you different answers. So I think this is the way to go, right? I think you need to think about LLM or this new sort of as a family of algorithms in which you try to find the one that fits you the best, right? And that's hopefully will. Right. And can I quickly answer to the previous question? Try to follow up, right? So I think this is a fascinating question. I don't know the answer, but and because we just started to do this, but what I would envision is that any impactful and important AI algorithm would be served by two people. One is, a medical expert with some training in data science, and one is data scientist. And so then I think all problems would be covered. Okay.
Great commentary. One other question, and we're getting close to the time. I think we go till 1:45. Is that right? Okay.
William Hoppus. I'm a data scientist at St. Luke's Health System up in KC. What's the lowest hanging fruit in predictive modeling, predictive health? We talked a lot about change management. We talked a lot about the problems inside health systems. And you get in this catch-22 where you want to provide value, you provide value, and then they give you more resources and you get moving. I saw a lot of wonderful, complex stuff. What's the simplest, easiest, biggest wins that you see hospitals and health systems could be doing?
Okay, that sounds like a good closing question. Who wants to take first?
I'm the least qualified, so I'll go. I think it's finding that really important gap where you just don't have anything. And I think rural radiology or interventional radiology is a pretty good example. Boy, your alternative is nothing. So maybe that's a space. And understandable is probably another one. Right? Simple is always better. But it's finding that one spot where everyone would agree, yeah, that would be really helpful to get a little bit better here, and then build your value. And it is a great idea to go small, build value, and prove, right?
Fantastic. Who wants next?
As complete non-expert, I would say that, again, the area of mental health sounds to me very exciting. And I mean, I don't think it's a simpler problem, but I think this is an area where LLMs can really, show some huge wins, especially for populations where currently, let's say, no help is available. So.
Stephen?
I think this question is no different from you asking a manufacturing company, a semiconductor company, or finance company. You're asking the same questions, basically. How can I contribute by analyze the data so improve your efficiency at bottom line? That's all it is. There's no generic question and answer for this question. You really look at your organization, what is missing, what's your culture, what you focus on. I think you just look at it that way.
So this was a very good panel. Lots of feedback, great questions from the audience. I don't know about this easiest target thing. I think there's an opportunity to think broader. What could we start doing today that would allow us to do prediction to really transform health systems? How could we activate people to care for their health, think about this? Like, I think the education paradigm is a great one. Huge opportunities to learn about our health from LLMs. Accuracy would be helpful, but a huge opportunity. So a great, exciting conversation. Thank you all for joining in. Maybe a round of applause for our panel.